Okay, so good morning. My name is Hannah Alley, and I'm a fourth year resident in Department of Neurology. And today I'll be discussing the neuroprotective strategies in stroke. So these are my objectives. First, we'll talk about the key mechanisms in ischemic brain injury, including excitotoxicity, oxidative stress, inflammation, apoptosis, and its relevance to therapeutic intervention, and then evaluate and kind of talk about some of these strategies that target these mechanisms, and see how we can apply those principles to clinical scenarios. Um, I have no financial disclosures, and as a reminder, majority of the things I will be talking about are therapeutic agents that are currently under investigation and are not approved for routine clinical use in stroke management. I put an asterisk because one of the agents is actually approved in Japan, in India. This content is solely for educational purposes. All data are preclinical research or clinical trials, and further studies need to be established for safety and efficacy. This is the CME code. Okay. So, as we know, stroke is a neurological disorder that results from the partial or complete cessation of blood flow to the brain. It is the leading cause of mortality and morbidity worldwide. And of the 15 million people who have a stroke every year, about 5 million of those cases will lead to death, and 5 million will have permanent disability. These are the current therapies in acute stroke. We have thrombolytics. We're all aware of alteplase and tenecteplase. Thrombolytics will convert plasminogen to plasmin and then break down the fibrin network constituting the thrombus. These have been in effect since basically 1995 and only really have like a 30% recanalization rate in most data. We're all very aware of antiplatelets, the trifecta of aspirin, Plavix, Brilinta. These all inhibit clumping of platelets. Tirofiban, eptividotide also inhibit by acting on the GP3-2B receptors. Glenzocimab is another experimental antiplatelet. It targets GPBI and reportedly has lower bleeding risks. I'm just not familiar in its clinical use at this time. We're also very familiar with anticoagulants. Eliquis, Xarelto, all these target some aspect of the coagulation cascade. And of course, the endovascular therapies such as mechanical thrombectomies and stents, which have a really good, really is a game changer in the stroke therapies. Another agent, fibrinogen depleting agents such as Ancrod, also have been used. It cleaves fibrinogen. Causes less fibrin. It causes less clotting. So I've never really encountered Ancrod. Does anybody know the molecular basis for Ancrod? Just out of curiosity. It's actually venom. So if you think about it, one of the mechanisms of injury or death from a snake bite is through blocking of the coagulation cascade. So it comes from the Malayan pit viper. So neuroprotection is a relative preservation of neuronal structure and or function. These are agents or procedures that protect against neuronal injury, particularly in this case, stroke, and has also some studies for neurodegeneration or protection for neurodegeneration in the brain. When discussing neuroprotection, it's really crucial that we understand what's happening at the cellular level. And this understanding will really highlight why mechanisms are targeted for neuroprotection. So this is a busy slide, I know, but it does illustrate the kind of the stroke pathology. So if you see I don't know if you can see my arrow. There we go. Okay. So here we have atherosclerosis, enlarged vessels, blood clots, embolus. These are the stroke etiologies. It causes cerebral artery blockade, that leads to decreased blood supply, and decreased blood supply to the brain leads to less ATP, oxygen, nutrients, and thus starts the cascade for neuronal death, starting off with calcium influx, leading to more glutamate release, stimulating the NMDA receptors, leads to more neuroinflammation, oxidative stress, and apoptosis. So I do just want to focus on these four main ones just to kind of help frame the way that we approach these neuroprotective strategies, mainly focusing on excitotoxicity, oxidative stress, neuroinflammation, and apoptosis. And if going back to the slide, as you can tell, there's many aspects or areas that we can target. And while there are other cell death pathways like ferroptosis, pyroptosis, necroptosis, Barthanatos, all these things, they're all very intriguing, and they also have specific neuroprotective strategies that target these mechanisms. But for the sake of time and just having things more simple, we'll focus on the ones I talked about. But it's important to know that there are agents and strategies targeting these pathways as well. So, beginning with excitotoxicity. After stroke, glutamate, which is an excitotoxic neurotransmitter, is released into the synaptic gap, leads to overstimulation, particularly of the NMDA receptors. So, if you see this diagram, increase the glutamate, triggers that NMDA receptors, and then it leads to the cascade of neuronal cell death. So let's talk about some of those strategies targeting excitotoxicity aspect. So we're all very familiar with memantine. Memantine, also known as Namenda. It's used for stroke treatment for its neuroprotective effect, primarily by acting on like a non-competitive inhibitor of the NMDA receptor antagonist. Because remember, here it hits the NMDA receptor. So it makes sense to target that. It mitigates excitotoxicity by blocking excessive calcium through the NMDA receptors, thereby preventing the downstream of the cascades leading to cell death. It reduces apoptosis. It actually offers neurovascular protection and maintaining integrity of the neurovascular unit and promotes neuroplasticity in some studies. Some of the side effects, though, are just like some headache, nausea, dizziness, bloating. But overall, the response for memantine has been relatively positive in stroke recovery. Another mitigator of excitotoxicity are calcium channel blockers. So researchers have focused on regulating calcium influx through in the nervous system, specifically targeting the neurons or the blood vessels. They've approached it by either reducing the extracellular calcium or blocking the influx using amlodipine and other calcium channel blockers. So in this study, where they went through at least 12 clinical trials with 95,000 patients, what they found was the subgroup that was treated with amlodipine actually had superior protection for stroke and myocardial infarction compared to other antihypertensives, but they largely did attribute this to better blood pressure control. In trying to address another, I guess, angle of neurotoxicity again is nerenatide. So nerenatide was developed for NMDA receptor inhibition again. So the preclinical studies did demonstrate it had the ability to reduce infarct volume and improve recovery. However, in the ESCAPE NA1, NA1 is for nerenatide, phase 3 trial, it did not improve the functional outcomes of patients when used with EVT or TPA. And what they found too, interestingly, was those who received TPA with the nerenatide actually did worse. So it either decreased the efficacy of TPA or TPA decreased the efficacy of nerenatide. And that information was actually also supported in the Reperfuse NA trial. So stroke recovery depends on the brain's ability to rewire itself, neuroplasticity. So they made this agent, S44819. And the reason why it doesn't really have a name is because it's technically still in studies and not really approved. It's a drug that blocks a specific type of GABA receptor, and that reduces the brain's natural inhibition of the damaged area. So in preclinical studies, what they found was this agent improved the stroke recovery of rodents, but it boosted brain activity in healthy individuals when they did TMS. Unfortunately, in this phase 2 Restore Brain trial, when they administered this medication to stroke patients within 6 days of stroke onset, it failed to demonstrate any improvement of MRS scores 3 months after stroke. And the factors that might have contributed to that is they really just measured motor symptoms. They didn't really evaluate the non-motor aspects of recovery, such as language. Moving on to another aspect of the cascade is the oxidative stress. So, when there is overproduction of free radicals, it leads to inflammation, cell death. So, it makes sense that neutralizing oxidative damage has been a target for these neuroprotective strategies. So, antioxidants work, by neutralizing free radicals that cause cell damage. Does anybody know what edaravone is usually used for? It's more popularly known for another neurologic condition. If Dr. Brown would here, would probably answer.
ALS.
ALS. So it's actually a synthetic free radical that's used primarily to treat ALS. There's this study is edaravone dux borneol, so it's just edaravone with borneol. And what is borneol? Borneol is an agent that's thought to have an anti-inflammatory effect on the blood-brain barrier permeability, so it allows other medications like edaravone cross the blood-brain barrier, and basically they have this synergistic effect to the brain. In this phase 3 trial, they did find that edaravone borneol versus edaravone alone actually helped improve the proportion of patients who received functional outcomes after 90 days. Notably, though, this study lacked a placebo control, and it didn't really involve patients undergoing like who had large vessel occlusions. So this was the TASTE 2 trial, where they had 1,300 patients who had large vessel occlusion strokes. They randomized these patients to either receive edaravone borneol versus placebo before a thrombectomy. And what they found was 55% of patients who did receive the edaravone had an MRS score of 0 to 2, while only 49% of patients who just received placebo before thrombectomy received an MRS of 0 to 2. And there were no safety differences that were observed. I didn't see, so if you look at the slide, it's just this article was actually just a protocol. I don't think we have the published results of this, but this was presented in the World Stroke Congress last year, suggesting that edaravone borneol could improve the 90-day functional outcomes in stroke patients if given within 24 hours of symptom onset, who have undergone mechanical thrombectomy or endovascular therapy. So epsilon, another agent for oxidative stress, is an organoselenium compound. It kind of mimics glutathione, offering like this antioxidant property. So it reduces inflammation, it scavenges ROS species, it inhibits apoptosis, and even modulates NMDA as well. So in this study, what they did was they induced ischemia in mice. They measured the cytochrome C levels, which is part of an inflammation, and they measured immunopositive cells. So immunopositive cells are cells that have basically responded to the agent. And what they found was giving epsilon to these mice, it reduced the levels of cytochrome C. And at 21 days, it actually increased the immunopositive cells. So, at least in mice model, it had positive effects. Another angle of neuroprotective strategies would be apoptosis. So, apoptosis neurons involves intrinsic and extrinsic pathways, both kind of having this inflammatory cascade. And one of the agents that targets the apoptosis, oral citicoline, you can actually buy this thing from Amazon. It's a compound that helps build cell membranes. It has its anti-apoptotic effect by blocking phospholipase activity, increasing catecholamines. It promotes membrane repair. And in some meta-analyses, they combined from stroke trials, they found that citicoline was actually more likely to have recovery from it if, after 3 months compared to just receive placebo. However, in the latest clinical trial, the one from Stroke Journal with Dr. Clark, what they found, the results of this study indicated while citicoline was safe, it really didn't improve the outcome of patients who were enrolled in the trial. They did mention that if there was post-hoc analyses, the subgroup that with patients with moderate to severe strokes might have benefited from it. So it's because it's, again, you can get it from Amazon. So the safety profile of it's probably okay, but the efficacy is still in question. So just CME code. Okay. So, neuroinflammation is another aspect of the pathophysiology in stroke. So, following stroke, you have necrosis, apoptosis, and then all these inflammatory responses involving the ROS, the chemokines, cytokines, both the innate, so like microglia, and then the adaptive, so like lymphocytes, are both involved in neuronal cell damage. So, it makes sense that limiting neuroinflammation is key to improving stroke prognosis. So, fingolimod is an oral sphingosine 1 phosphate receptor analog that's usually used in MS. It decreases circulating lymphocytes and reduces CNS inflammation. So in this study in 2014, what they found was when they administered fingolimod to patients with acute ischemic stroke, their NIH scores actually improved from 7 to 11, and the patients who didn't receive fingolimod, their NIH scores actually was worse, something about 9 to 10. They do note that the greatest improvement of these patients are the group that benefited the most are those with an anterior circulation stroke. So patients with lacunar stroke really didn't get much benefit. I'm not sure why. But at 90 days, what they found was basically those who were treated with fingolimod for at least 3 days has lower NIH scores, higher Barthel index scores, and higher functional dependence. In another study in 2015, after that, they did the same thing where they had two groups of stroke patients, both receiving TPA. One was receiving fingolimod, the other didn't. So about the census is about 20 to 25 per group. So what they found was they were given treatment for about, I think, 0.5 mg per kg, and then for just about 3 days. And what they found was compared to those who received TPA alone, those who got fingolimod plus TPA actually had lower circulating lymphocytes, smaller lesion volumes, less hemorrhages, better NIH scores, and better recovery. It really did sound promising, but remind you, this is only just 20 patients that they studied this on. Another angle of neuroinflammation was a study looking at something that can target microglia activity. So MIR203, which is a microRNA, it regulates gene expression. It's like a dimmer switch for for neuroinflammation, where it reduces microglia activation. So if you reduce, what they found was if you increase the MIR23, it reduces this MYD88 or MyD88, which is a protein in the neuroinflammation. And therefore, you suppress the pathway for inflammation, leading to less microglial activation, reduced neuronal damage. I know I only really want to talk about the four aspects, the four main things of the pathophysiology of stroke, but I did want to touch on mitochondrial stabilization. Mitochondria, they're central to apoptosis after ischemia. So the two main aspects of this very busy slide I want to focus on is the cytochrome release, as well as mitochondrial dynamics. So I don't know what mitochondrial dynamics is. It's very molecular, way above my pay grade, but just know that it's important to have a balance of this fission and fusion, and they're essential for neuronal survival. So, calcium-induced cytochrome C release triggers enzymes leading to cell death, but this can actually be blocked with MPTP inhibitors, such as cyclosporin A or bongkrecic acid, and it had shown kind of these neuroprotective effects. For those of you who don't know what bongkrecic acid is, which I also had to Google, it's a toxin, actually. It's a heat-stable toxin produced by Burkholderia bacteria that's seen in fermented coconut and corn-based products. Um, After stroke, again, we talked about the cytochrome. This is the part that deals with the mitochondrial dynamics. So after stroke, there's going to be disruption of the mitochondrial dynamics leading to excessive fission. So remember, with mitochondrial dynamics, there has to be balance of fission and fusion. So when there's excessive fission aspect, they develop these inhibitors, DRP1, which was shown based on their studies to reduce infarct size, which basically highlights that targeting mitochondrial damage could be a promising neuroprotective strategy. Stem cell therapies, as we know, kind of really offer some promise in stroke. It promotes brain tissue repair, neuronal regeneration, it reduces inflammation. The four main cells that they do target are the mesenchymal cells, the hematopoietic blood stem cells, neural stem cells, epithelial stem cells, and the newly identified subtype of the mesenchymal cells are the mu cells. So what they found was when they injected mice who had strokes, with the mu cells would engraft themselves to the damaged tissue. They would differentiate and actually improve the outcome of the mice. This was done through like neurogenesis, neural network repair, even axonal growth. And if you look at the table behind this study, these are all the clinical trials evaluating stem cell therapy. And I kind of knew about this just because one of the studies is actually in Houston Methodist. So I'll let you know what the results show. Between 2011 and 2015, another RCT evaluating stem cells was conducted. After initial safety and evaluation, they had about 130 patients. And what they found was that after 90 days, there wasn't really any significant evidence or difference in global stroke recovery between the stem cell group and the placebo group. But there weren't any dose-limiting toxicities, no allergic reactions, no significant adverse events. In another study called the Treasure Trial, which was done in Japan, again, evaluated about 200 patients with moderate strokes. They randomized to either receiving like the 1.2 billion stem cells or placebo within 36 hours after stroke. And they found was multi-stem was safe, or the stem cells were safe, but no significant difference in the primary outcomes at 90 days or even at 1 year. And so while multi-stem was safe, it didn't really improve functional outcomes when given within 36 hours, 18 to 36 hours after post-stroke. So while stem cell therapy for ischemic stroke, I just want to make sure, okay, my GIF is working. Okay. While stem cell therapy for ischemic stroke holds great promise, it does have its challenges. So patient responses will vary, and safety concerns of like teratoma formation and cell differentiation, determining the best cell type, dose timing, even the delivery method is still all under investigation. So the neuroprotective strategies I've talked about are actually just a small portion. There's actually a lot of neuroprotective strategies. It's not a new concept. Since the 1990s, we've had over about 500 clinical trials evaluating more than 200 therapies. In the study that I read, and since 2018, we've only really had 9 that made it to phase 3. And the reason probably why we don't see more of these is that preclinical studies have not translated well to humans. Remember, majority of the studies were in mice. So rodents, they don't always mimic the complexity of human stroke pathology. The timing of treatment can be narrow, so we still want to give our patients the standard of care. So if they have a very narrow window, to recruit them, to explain to them that, these are experimental studies, it takes some time. Also, excuse me, they didn't really evaluate giving these therapies. I think one of the stem cell therapies was giving it within 36 hours after stroke, but didn't really evaluate what about 1 week after stroke when there's less inflammation, maybe better penetration of blood-brain barrier or something. Other thing, plus stroke is a complex event with multiple pathways. So if we target, most of the agents really just target one aspect and trying to prevent the cascade, but maybe targeting multiple aspects is what's necessary for it to really achieve what we wanted to achieve. And finally, clinical trial designs and endpoints can be tricky, as most of them really just evaluate the MRS, the motor recovery. Sometimes they don't evaluate the non-motor symptoms. I always wonder about some of these patients who get evaluated 90 days after because when we administer, say, the medication, the trial medication, we find out that on discharge they can't afford or they don't have insurance for acute inpatient rehab, or they can only do 2 weeks, or they only could do 1 week. And no one really follows up how the consistency and the standardization of how much therapies they get within that 90-day mark, since we're so keen on measuring how they do after 90 days. So I know it's a lot. A lot of the things that I talked about are very like molecular, very pharmaceutical level of thinking. But what can we do now in terms of for our patients? So um, repurposing medicine. Due to limited resources and urgent need to follow therapies, drug repurposing actually offers a fast track for developing effective strategies for stroke. So things like acetylcholine, antidiabetics, calcium channel blockers, antibiotics, these are just some of them. I'll kind of talk about a few. So, researchers, they compared the neuroprotective effects of calcium channel blockers, nimodipine and nifedipine, and they measured these called, I guess, NP cells. And what they did was these cells, they exposed them to oxygen, glucose deprivation, as well as withdrawing essential growth factors necessary for neuronal survival. And what they found was nimodipine offered better protection than nifedipine. But again, these are just cells, not in humans. Metformin, actually. So we don't really start metformin inpatient. We always say outpatient or on discharge. But metformin, if you think about it, can in these studies alleviates neuroinflammation. They suppress some inflammatory pathways. They reduce pro-inflammatory cytokines. It regulates anti-inflammatory mediators. In some studies, it actually showed to preserve blood-brain barrier integrity, reducing disruption and subsequent neuroinflammation. Azithromycin even offers neuroprotection in stroke by promoting anti-inflammatory polarization, reduces pro-inflammatory cells, it inhibits pro-inflammatory cytokines, also reduces blood-brain barrier damage. I think this was more of theoretical rather than actually seen in that study. It promotes neurogenesis and angiogenesis as well in some studies, which was surprising. Melatonin provides neuroprotection in stroke by reducing oxidative stress, scavenging reactive oxygen species, enhancing antioxidant enzymes. It inhibits pro-inflammatory cytokines. It prevents ferroptosis, and it protects blood-brain barrier integrity as well. So this table does show some of the repurposed drugs for ischemic stroke that were made for something else, but something to consider, like in my head, if I have a patient who's newly hypersensitive, have a stroke, then maybe just start them on amlodipine. It's calcium channel blocker, same for hypertension, but it will also have anti-inflammatory effects by reducing the calcium. What else? Maybe metformin. Maybe you could start it sooner rather than later instead of starting at discharge. Um, Obviously, I don't think we should do naloxone all the time, but if your patient has opioid, problems and you need naloxone, why not? Um, Citicoline, used for, again, it's on Amazon. Like you can buy it on Amazon. Maybe we can consider melatonin. I take melatonin every night. Maybe you can put in our stroke order set, just order for all our patients with melatonin. It doesn't really hurt. So in summary, A solid understanding of ischemic stroke pathophysiology is really essential for developing these neuroprotective strategies, and targeting specific steps of the cascade will guide therapeutic development. Unfortunately, most of the strategies that were developed or in preclinical studies were promising, but really failed to reach bedside application. So at this point, maybe repurposing would be a practical approach to giving our patients some of these therapies, and using the well-characterized drugs for safety profile will probably help most of our patients. So, any questions at this time I can answer? Yes, Prachi. Sorry, what was the question? I'm so sorry, I'm deaf. Yeah. Yeah, so some of the studies, some of the studies were like, they involve both. They involve patients who have low, so lots of them either involve the low NIH patients or the higher NIH patients. In one of the studies for the citicoline, they did say that if you do a post hoc analysis, it might benefit those who did worse. So I think in most of them, they had an average, I'm just ballpark guessing, probably about 6 to 10 is their average of the NIH, of the majority, because a lot of the studies, like they evaluated LVO patients as well. So that NIH automatically is like above 6. Would we want to give it to low NIH patients? Will we benefit? Uh, I think you'd want to like subgroup that, because if you're going to do something in my head, if they have a low NIH, they're probably going to do better even without treatment anyway. So I'd probably reserve these for those like at higher NIH, just because they need the most help. Hey, Dr. Parker. Yep. No. I'm gonna convince Nico to give fingolimod too. I'm gonna get convince Nico to give fingolimod. Mhm. Yeah. Yeah, mhm. Yeah, right. Yeah. Hmm. Mm, mm, mm. Yeah. Yeah. Dr. Brown's here. Just wanted to let you know one of the things I talked about was edaravone for stroke. Over. Oh, you saw it? Yeah. For edaravone, it did really well in the World Stroke Congress trial. So for pre-thrombectomy patients. Sorry? Yeah, it is approved in Japan, in India, and I think in China, in those for stroke. It's actually approved for those cases. So, mm, yeah. I think edaravone is a big it's one of the major ones. And actually if when I was reading on it, fingolimod was pretty interesting to be given. It's only given for 3 days, but it had promising results, but it was a very small population of patients. It's just like 20 patients. In terms of the repurposing, I think what we can apply here would be like things like melatonin and amlodipine, because amlodipine really is just most, though it's for blood pressure control in theory, it will still help. So I would choose those. Yeah, Nico. Sure. Right. Mm, yeah. It's for mice. Yeah. 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 Everything works for mice. And then I think that's one of the downfalls of not the downfalls, but one of the things with neuroprotective strategies, majority really are in just preclinical rodent models, but majority really fail to make it to bedside. And so um like I said, there's just like more than 200 trials that have failed. There was another presentation that I watched on it, and it talked about how there's actually more than 200 being studied, and still we only have so like probably 20 that are left, or are still in the process of not being rejected, I guess. Um, to answer your question, Fingal, it's a good question. I think the overall is just reducing the lymphocytes, circulating lymphocytes and overall inflammation process. I think that's their main thing. I don't know why they only administered it for 3 days. I think in both studies in China, the 2014, 2015 one, they only administered for 3 days. So I'm not sure why. Yeah. 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 SB1. Right. Right. Yeah. Right. Right. So I'm not sure if I'm trying to recall. I don't think I encountered whether or not they only give it for 3 days because of bradycardia, but I think that was just their goal was to give it that. Yeah. 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 Good point. Okay. Yeah. Or spinal cord injury. I'd be out of a job though. 60 hour. Yeah. The within the insult. Right, right. And yeah, that's very important. And I think that's why one of the limitations really is that most of the agents just target one aspect of it. But you do need to target like other aspects and for other several days as well. Some of them they studied the effect, sorry, they administered the medication within 5 minutes, some within 18 hours, some within 36 hours. And the variability of that alone really makes it harder to measure any form of true inflammatory or anti-inflammatory effect. So, yeah, that's why while this presentation is supposed to be encouraging, it was actually disappointing in the long run, just because of how we have so little to offer our patients within that crucial window. So I think the best part is the most we can do is really just repurposing that we can what we have. I wouldn't offer any of these to my patients just yet. Just even I'd probably just do amlodipine and melatonin in practical sense. Right. Um, yeah, but yeah, yeah, that'd be ideal. I don't know. I guess since I rotated with ID, I feel like unless I have something to go off on in terms of giving antibiotics, I might not. I'm not sure how they'd feel. I mean, we tried to convince a lot of people to start our patients on antibiotics, and that doesn't happen. I'm not sure if they'll be on board with starting azithromycin. But it's a good, basically, if my patient has an infection too, I'd probably just maybe kill two birds with one stone. But um, yeah, yeah. I'm I'm not sure. Yeah, no, no, I'm not sure because yeah, yeah, for the and they're inside, yeah. Hmm. Yeah, it got better. Hmm. Yeah, it's disappointing, but it's something to think about if ever you want to go into like more clinical trials and research and things. It's an avenue that Is this, I don't know, maybe it's like discouraging, but maybe there's hope. Maybe you'll figure out something. We believe in you. Hmm? No, they only did amlodipine. Oh, actually, no. I think they did amlodipine against all other antihypertensive, which included nifedipine in one of them, including ARBs. It was still amlodipine was better. I think in that stroke trial. Okay, so this was our picture on day one of orientation and just finishes. What? Sorry? Oh, yeah, I forgot. What? Oh, great. Oh, they all look the same. We all look the same. What is the question? Oh, two messages. Sorry. Thank you. Do you have any pharmacointerventions that also improves neuroplasticity? All the basically, I think general blanket would say antioxidants help in the things that I've read. They all kind of, if you do a Venn diagram of all the agents that have antioxidants, targets NMDA, all of them are have some um, similar mechanisms. So I would say probably antioxidants would be the one that helps the most. But if you think about NMDA, also targeting NMDA receptors, so NMDA receptor antagonists would also help with neuroplasticity. So, okay, all right. Well, thank you, everyone, and good luck.